Tell us how you evaluate and manage visual changes and eye complications associated with immune checkpoint inhibitors. As with other immune-mediated adverse events, patients may develop inflammation of the eye or different sections of the eye. Typically, the ocular structures have special mechanisms to prevent inflammation, such as creating ocular immune privilege. However, the mechanism of eye toxicity with immune checkpoint inhibitors is really not well understood. Patients may present with pain, ptosis, visual changes, injected sclera, lid and conjunctiva edema, photophobia, floaters, blurry vision, eye pain, blind spots, change in color vision, or even redness. Visual changes may be due to direct eye inflammation or to other causes. Most common eye toxicity that is immune-mediated is dry eye, and this has been reported in 1 to 24% of patients. Uveitis has been reported in 1%, but we've also noted conjunctivitis, scleritis, iritis, blepharitis, retinitis, optic neuropathy, macular edema, myasthenia gravis with ocular involvement, and this presents with ptosis and diplopia, and even retinal vasculitis. There are some other causes that might need to lead to visual changes as well, so one needs to keep in mind and rule those out before assuming that they are just immune-mediated. And these include brain metastases, myasthenia gravis, and some other targeted therapies that the patients might be receiving in conjunction with the immune checkpoint inhibitor. Evaluation. This can be very complicated to diagnose, so patients really should see an ophthalmology specialist, somebody who specializes particularly in retina and uveitis. A fundoscopic eye exam is going to be required, and in some cases, an MRI of the brain. Management is going to be dependent on the part of the eye that's being affected. So for dry eye syndrome, patients often can just have relief with hydrating artificial tears. You want to make sure that they minimize any eye irritants. If it's immune-mediated and thought to be uveitis or panuveitis, steroid eye drops may be sufficient. With more advanced cases, however, topical periocular steroids may not be enough, and patients may require systemic steroid use as well. And that would be dosed, as with other toxicities, at 1 milligram to 2 milligram per kilogram per day, and then tapered until the resolution of the symptoms. However, I want to just highlight that ophthalmologists need to be vigilant for even more serious, irreversible ocular eye side effects, such as corneal perforation related to severe eye syndrome, corneal graft rejection if a patient has had a graft in the past, and even be concerned with life-threatening myasthenia gravis if a patient is not responding to the topical steroid. So they need to be evaluated for that.